Hi, in this presentation we will be talking about fungating wounds. The presentation has been prepared by Dr. Pooja Sadana, Associate Professor of Department of Community Medicine, SGRD University of Health Sciences, Amritsar. She is Assistant Vice President of Punjab Chapter of National Association of Palliative Care for Ayush and Integrative Medicine. Fungating wounds are a complication of cancer and may develop in patients with advanced disease. They are caused by direct infiltration of the skin, tissues, mucosa, blood or lymph vessels, or by a tumor or metastatic deposit. They can be painful, produce high levels of exudate, cause bleeding and malodorous. Managing fungating wounds can be challenging for nurses, especially in terms of implications for patients and of quality of care. The term fungating refers to a malignant process of both ulcerating and proliferative nature. Fungating lesions are fast growing and typically resemble a cauliflower or fungus shaped structure extending beyond the skin surface. These ulcerative lesions are characterized by deep craters with raised margins. So, we can see the example of fungating wounds. What are the problems due to fungating wounds? The problems are physical due to the wound itself. There may be psychological problems, social problems, spiritual problems and financial problems too. Physical problems are pain, malodor, infection, bleeding, exudates and maggots. Whereas, the psychological problems may be altered body image, sexuality, fear of death, depression and anxiety, shame and isolation, many times due to malodor. Problems due to fungating wound, there may be social problems or even spiritual problems. Family isolation could be there, social isolation could be there, social stigma or fear of contagion could be there, effects on family are there, effects on sexual relationship and marital disharmony are also there. Spiritual problems may be interference with religious rites, punishment from God, as the patient starts thinking and cursing himself that why he has been punished for this particular cancer as well as the wounds. Fear of impending death and sometimes even existential dilemmas are there. So, managing the symptoms, healing is not the objective of wound care, symptom control is the primary goal. Holistic assessment of the patient and wound should be done. Holistic psychosocial support of patients and families is required along with physical care. Wound assessment, etiology or cause of wound. Example, fungating wound care is directed towards symptom control, while a pressure ulcer requires pressure relief. Location of the wound, size, depth and shape of the wound. To monitor changes in size to ascertain if the wound is healing or deteriorating. Amount and nature of exudate, order and type of tissue present. Signs of infection, nature and type of pain, condition of surrounding skin, episodes of bleeding and finally, if there are any maggots present. The objectives of wound management, maintenance of optimum wound humidity to minimize pain, non-adherent dressing to prevent trauma and thus minimize pain during dressing changes, facilitation of debridement if appropriate, control of symptoms such as excess exudate, bleeding, malodor, pain and maximization of cosmetic acceptability. Now, here we see persons with non-healable malignant wounds. The treatment could be symptom management, support care and preventive measures. Local wound care manages hopes, which may be elaborated as hemorrhage, odor, pain, exudate and superficial infection, and patient centered concerns are the fear or anxiety, depression, body image and coping deficits. Management of pain. Minimizing pain should be the target. Remove previous dressing by soaking with saline to prevent pain and bleeding. Deep pain, aching, stabbing, continuous. So, adjusting systemic analgesic. For superficial pain which is burning or stinging, local application of lignocaine, sensocaine or opioids, and for incidental pain ketamine can be used. Topical agents or dressings play a major role in alleviating the wound related to pain. Slow release ibuprofen foam dressings are effective in providing rapid and prolonged pain relief. Alternatively, local anesthetic cream mixture of lidocaine 2.5% and prilocaine 2.5% should be applied liberally on the intact skin and covered with an occlusive material for 30 to 45 minutes to ensure adequate skin penetration, and has been used to reduce sharp debridement induced pain. And when you are using any medical interventions, do consult the nearby doctor. For malodor management, daily cleansing and dressing is important. Topical application of metronidazole gel and cream. Alternatively, gauze can be soaked with intravenous metronidazole solution to use as a compress, or 200 milligram tablets can be grinded into powder and sprinkled onto the wound surface. If dry or painful wound, apply metronidazole powder and xylocaine jelly mixed. Benefit is noticed only after 12 hours. Activated charcoal dressing has been used to control odor with some success. Systemic antibiotics can be given. If topical treatment is not successful, put odor absorbing agents such as kitty litter or baking soda beneath the bed to reduce odor. Infection, debridement, crucial step to remove devitalized tissue which serves as a growth media for bacteria. Aggressive debridement is not recommended in malignant wounds, risk of causing pain or bleeding and creating a larger and deeper portal for bacterial infection invasion. Cleansing solutions including saline or water are usually recommended to remove surface debris due to low tissue toxicity. Daily dressing is done with metronidazole powder. Remember, hydrogen peroxide or even betadine should not be used in such cases. Bleeding management. The prevention, gentle removal or dressing with normal saline, apply local pressure. Sucralfate powder can be used. Hemlock solution 1:100 dilution. Hemostatic property dressing, gauze soaked in adrenaline or tranexamic acid or sucralfate liquid, systemic ethamsilate, surgical procedures, and again palliative radiotherapy for profuse bleeding may be given. Here we can see the maggots in the wound, and it is a situation which is very painful, not only in terms of physical pain, but certainly psychological, social as well as spiritual pain. Now, to remove these maggots, we use turpentine oil dressing. There can be physical removal of maggots, because once we put turpentine, the maggots will come out and then we can remove them physically. We can use camphor powder, systemic or local antibiotic may be given, and again reassurance is important to make the patient confident. Wound exudates, hydrocolloid dressing can be given, calcium alginate dressing can be applied, transparent adhesive dressing can be applied, or activated charcoal dressing can be applied. Now, training of caregivers is very important. Knowledge, attitude and practice should be assessed. Practical demonstration of wound care should be given. Regular follow up should be there. Realistic goals of care, that is improving quality of care and palliation of the symptoms, is very important. Teaching saline preparation and sterilization of dressing materials, how to use them so as to reduce the cost. Hand washing before and after the dressing is very important, and how to dispose the waste materials. Preparation of saline and how to sterilization of dressing materials. For that we use old cotton cloths, wash thoroughly with soap and water and dried, cut to the size of the wound, sterilize by steaming in a pot for 20 minutes. So, we can always use a pressure cooker for that. Remove the lid as soon as the stove is turned off. Keep this sterilized materials in a clean and dry container. For saline preparation, 2 teaspoonfuls of salt in 1 liter of water, bring to boiling point. Thank you.